Welcome back to the channel. Today we're taking a deep dive into one of the most common joint disorders seen in clinical practice, osteoarthritis of the hands. Before we begin, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. Whether you're a medical student, a healthcare professional, or someone managing this condition, this video will give you a clear, evidence-based review from diagnosis to treatment and beyond. Osteoarthritis of the hands is a degenerative joint disease that involves gradual breakdown of cartilage, joint space narrowing, and bone remodeling. It's incredibly common, especially in women over the age of 50. Up to 50% of women and 25% of men over 65 have signs of hand OA on X-ray. Risk factors include aging, female sex, genetics, past joint trauma, and surprisingly obesity, which may exert metabolic rather than mechanical effects on the hands. The process begins with stress on the cartilage, triggering inflammation and release of enzymes that degrade joint structures. Over time, we see osteophyte formation, joint space loss, and mild synovial inflammation. The joints most often affected include dips leading to Heberden's nodes, pips forming Bouchard's nodes, the base of the thumb or first carpometacarpal joint. Patients usually report pain worsened by use, stiffness lasting less than 30 minutes, decreased grip strength, and visible joint nodules. Advanced cases may show crepitus, limited motion, and deformity. On exam, expect bony swelling, tenderness, reduced pinch strength, and no systemic features like fatigue or fever. X-rays show joint space narrowing, osteophytes, subchondral sclerosis, and cysts, often asymmetrical. ESR, CRP, and anti-CCP are usually normal, helping to rule out inflammatory arthritis. It's key to distinguish hand OA from rheumatoid arthritis, psoriatic arthritis, gout, and erosive OA, a more aggressive subtype with central erosions and inflammation. Start with education, joint protection techniques, hand therapy, and adaptive tools. Splinting, especially for CMC1 OA, can be incredibly helpful. Topical NSAIDs like diclofenac are first line. Oral NSAIDs, acetaminophen, capsaicin, and occasional steroid injections for the thumb base can also be used. Tramadol is reserved for severe cases. For persistent pain or deformity, options include arthroplasty, joint fusion, or even joint replacement. Glucosamine and chondroitin may support cartilage and reduce mild inflammation. Evidence is mixed. Some studies show modest symptom relief, but major guidelines remain cautious. If tried, they should be used in pharmaceutical-grade form and evaluated over 3 months. Avocado oil extract may reduce IL-1 and TNF-alpha, offering anti-inflammatory benefits. More evidence exists in hip and knee OA, but it's a safe, natural adjunct for select hand OA patients. Routine follow-up focuses on tracking function, grip strength, and flare frequency. Reassess medication effectiveness and make sure patients have access to adaptive tools and support. Hand OA is often slowly progressive. Many maintain reasonable function, but erosive OA has a more severe course and needs closer attention. So that's your comprehensive look at hand osteoarthritis. From pathophysiology to supplements like glucosamine and avocado oil, we've covered it all. If you found this video helpful, give it a thumbs up, subscribe for more rheumatology insights, and drop a comment below if you'd like to see a video on erosive OA or hand therapy techniques next.